Thank you for joining us. I want to welcome everyone to the final installment in STS's Summer Series of webinars. This series has run every other week and featured presentations and panel discussions on a variety of topics relevant and important to CT surgeons and the world of CT surgery. STS would like to thank Medtronic for their generous support and sponsorship of this webinar and the STS Summer Series. Today's topic is controversial cases in mitral valve disease. We want to make this webinar as interactive as possible and hear from you, the audience. To this end, you may enter questions through the Q&A feature in Zoom. The panelists will try to respond to as many questions as possible. Please note this webinar is being recorded and will be available tomorrow morning on the STS website, STS YouTube channel, and the STS Surgical Hot Topics podcast. At this time, I'm pleased to welcome our moderators for this session, Dr. Gorav Ailawadi and Dr. Tsuyoshi Kaneko. Dr. Ailawadi is the chairman of cardiac surgery and co-director of the Frankel Cardiovascular Center at University of Michigan Medical School. And Dr. Kaneko is a cardiac surgeon and director of aortic surgery at Brigham and Women's Hospital and assistant professor of surgery at Harvard Medical School. Dr. Ailawadi, Dr. Kaneko, I'll now turn it over to you.
Thank you, Wesley. What a summer it's been. I know all of us have dealt with probably an unimaginable 2020 with COVID and riots, and I sincerely hope that all of you are safe and that you've all begun the ramp up and hopefully well on your way to resuming your practices and delivering safe and efficient care. As you know, this is a controversial series. We've had our most recent one in adult cardiac surgery was about a month ago, focusing on aortic stenosis. This session is going to focus on complex mitral disease. As we know, there are many options now with transcatheter therapies as well as surgery, including high-risk surgery. We will ask as much audience participation as possible. We'd love for you, the audience, to provide any questions using the Q&A. I also want to thank Medtronic for their support, without which none of the summer series would have been possible. So at this point, I would like to turn it over to Tsuyoshi Kaneko. Yoshi, can you please introduce our outstanding panelists?
Yeah, thank you, Gorav. So we have a world-class panelist today from all over the country. So first up is Dr. Vinay Badhwar. He's from West Virginia University. Dr. Mayra Guerrero from Mayo Clinic. She is an interventional cardiologist. Dr. Rob Smith from Baylor Plano. Dr. Posaraja from Minneapolis Heart. He's an interventional cardiologist. Dr. Gilbert Tang from Mount Sinai. And Dr. Dee Wang from Henry Ford. She is a cardiologist who specializes in imaging. We'll be going over a total of 4 cases with complex mitral disease, and we will present the case, images, and sort of ask for panelists' opinion as well as the audience opinion of what kind of treatment we should be performing, and afterwards we will sort of tell you what the presenter did in their own cases. So I'll
make one comment. Those pictures are not fair because I look much older than everybody else. That's just a comment. Look how young everybody looks. Rob, man, I remember you then. All right, Yoshi, go for it.
All right, thanks, Gorav. The first case is 82-year-old active female. She was apparently traveling all over the world with known severe mitral regurgitation. I'll show you the echo from a year ago, presented with hypoxemia and also fatigue. She's got past medical history, but nothing quite significant that will preclude her from surgery. She acutely decompensated over the past few weeks and was transferred to CCU. She was originally admitted to the normal floor, but during the course of the hospital stay, she worsened and was transferred over to the CCU. Her STS score for mitral valve replacement was 5.2%. So this is the echo from a year ago. You can see that in this view, you can see the prolapse leaflet. There was not a great 3D echo, so I can't tell you exactly where the prolapse was, but it was on the P2 segment, a little more towards the P3 side. The P side was 1 centimeter, and the mean gradient across the mitral valve at that time was 7 millimeters of mercury. Hold on, this is not right. Sorry. This is the TEE after admission, and you can see an additional prolapse in addition to the MR segment that we saw originally in 2009. I will show you a 3D echo, and there's a torrential MR that is seen on the color Doppler. And this is the 3D echo. You can see that originally this portion had a prolapse from the previous 2019 echo, but there's an additional ruptured chordae that you can see causing a significant MR. The mean gradient at this time was 7 millimeters of mercury. The MVA was calculated as 3.9 square centimeters. This was relatively a generous calculation, I would say. It was probably lower than that. The frail gap is less than 10 millimeters, and the coaptation depth is less than 11 millimeters. So this was a chest x-ray right before she got transferred over to the CCU. So clearly she was in flash pulmonary edema from this acute MR. And I think the slides were not in the right order. So what would you do at this point? So would you consider this patient for a mitral valve repair with a partial ring or using neocords? Mitral valve repair with partial ring and resection. Sorry, that was the first option. Mitral valve repair with complete ring and resection. Mitral valve repair with complete ring and neocords, or mitral valve replacement. Last is the mitral clip. Sorry for the slides not working properly.
Hey, Yoshi, one other quick thing. Can you maybe let everybody know your the STS score? Do you remember what that was roughly?
So 5.2 for mitral valve replacement, and this is in the light of urgent procedure. Mitral valve repair was slightly lower. It was 4.
So she's currently in the CCU. Is she intubated? Is she on a lot of oxygen?
She's not. She was not intubated, but she was requiring 10 liters of oxygen before intervention. So.
And her renal function is okay?
Her renal function is okay. Creatinine is 1.1.
Okay, and does she look frail?
She looks borderline frail.
Okay, all right, let's see what everybody would do then.
So in the waiting time, can you pull it up, Wes? Okay, so 26% of the audience would perform mitral valve repair with complete ring and neocords. So in this particular,
I think more important than that is, whether the technique's probably not as important. Looks like almost 60% would try to repair this valve, and about 20% would replace, and 20% would do clip, would recommend clip.
Okay, so going back to what we did in this particular case. But
you want to see what do the folks here think, I guess, before you get into the various techniques that are options. I get. Vinay, you want to start? And I guess Vinay made a good point. We should all probably mention our disclosures. Vinay, if you want to start, if there's any particular disclosures.
No financial disclosures, though I have a non-remunerative position with an Abbott with regards to the Tendyne trial. So, I mean, obviously you got this slide with a mitral clip. It's good that it sort of shares what the audience is, probably majority surgeons perhaps. But as you see, you've got a whole panelist that all do mitral clip and transcatheter mitral therapies. So it goes down to risk. From an anatomic perspective, the valve looks highly repairable. What's not mentioned in your list is the adding of a surgical ablation procedure, or a maze, and left atrial appendage occlusion simultaneously, I think would be additive if surgical approach would be approached. There's a obvious P2 flail, but there's also a secondary cord just to the medial aspect that would be relevant as we do a transcatheter consideration or surgical consideration. So there's a dual mechanism, same P2, but dual mechanism. Obviously primary MR, so I think it looks highly repairable. Not to worry about the gradient, since it's likely secondary to the tricuspid regurgitation, but I'm sure Myra and Didi perhaps can comment specifically on that. But obviously in someone that's in extremis, even though her STS risk is not prohibitive, it's quite high. This type of patient will also be answered in the coming repair MR trial, but I think it's prudent to proceed with a clip on this particular patient.
Rob, you feel differently? I mean, I guess really it comes down to what is the patient's real risk, right? And we have an STS of 5, but Yoshi's painted a picture that they're in the ICU on a lot of oxygen with some pulmonary.
Yeah, I think that's an important piece to the STS, right? It's an instantaneous number that doesn't take into every variable that's, out there that's going on with this patient's risk. Number one of which is frailty, which we now use as a second measure of assessment when we're looking at these patients from the heart team approach. So as Vinay was talking about, I think that you're really looking at anatomically a valve that's very repairable, but the question is she operable at this point? And so in this setting, with her being in the CCU, worrying about her oxygen level, is she trending towards one of improvement and therefore compensation? And you can wait for either a clip or surgery if she's trending in the right direction. But if she's not, or she's stalled, I think clip is the right treatment for this. Now, I guess in that setting, we have a gradient that's elevated, right? So that's a concern, although most of it is likely due to the MR. But we also have a very small valve area, opening area that was calculated. So one of the problems with the valve areas calculated sometimes on the preoperative TEs, particularly if it's been in a patient who's not intubated and they're doing a high-risk TEE, they get through that pretty quick. And even though they can do some of these measurements kind of post hoc, I think the important thing is really a good TE measurement at the time of the procedure is really where you do it. So you can plan for a device and plan for going in for a mitral clip and then say, hey, this is not the right procedure, and later decide to bail with just a really good TE at the time of the procedure.
Myra, what do you think? You're muted, Myra.
Can you hear me now? Okay, yeah, sorry about that. Well, I don't need to repeat what has been said already about risk. It's always about risk, but also about what the patient wants. And if you ask me, if I put myself in the place of the patient, 82-year-old in the ICU, I know one option can be a surgical option that gives me a much better resolution of the regurgitation and maybe perhaps take care of the left atrial appendage. But at that age and at that risk, as a patient, I would choose a mitral clip. And as an operator, I know it's not the perfect anatomy, but I think with a 3.9 area and that gradient, which we all think is due to MR, probably a 1 NTE device will give us enough reduction of the regurgitation just to help her feel as she felt maybe a couple of years ago. So I would vote for a clip, small.
Paul, what do you think? Do you agree with what's been stated, or any other thoughts?
I think it's a great discussion. Not a whole lot to add. I think the main question I always have for my surgeons in these situations, and particularly in this age group, is how hard are you going to try to repair this valve? We know most of the survival benefit for repairs in relatively younger patients, somebody over 80, particularly somebody who is borderline shock. I'm not sure what the survival benefit of repair versus replacement is exactly.
Would you be upset if your surgeon just went in and replaced it quickly and got out? Would you be upset at an 82-year-old?
No, not at all. Not at all. But it has relevance, because if you're going to replace it, then, would you want me to have a chance at trying to repair it with clip? And that goes to Vinay's comment earlier, or actually maybe it was Rob, saying that, well, you can try the clip, and if it doesn't work, you have a bail, which is replacement. And so that's where that nuanced discussion comes into play, because if you're dead set on replacing it, then giving it a shot at clip, which is pretty good chance actually, I think, of getting a good result, is a reasonable way. But if you really want to repair, then obviously the surgical repair is going to be more likely to succeed.
Yeah, I think that's a good point. Didi, any other thoughts? Anything on the anatomy? Are you concerned about the small valve area? Is this going to need more than one device, you think?
Well, in these acute flails and cryogenic shock, the most important thing is to get them on a better respiratory status. The problem with this 3D is that, it's at the time of the acquisition, but with these acute flails, they end up rupturing more cords by the time they come into the cath lab. So there's obviously a P2 flail, but there's multiple chordal ruptures there on the medial and lateral, and there's a hint of a P1 flail too. And given this attack strategy, you already have a baseline mitral mean gradient. I wouldn't go with a G4 device. The larger, the wider devices in this small annulus is probably not going to be conducive because the P2 segment's acting as two independent portions. So one device, but then the other question would be redo and the risk of reintervention. If we bring the V wave down enough, she might have symptomatic benefit, but if we don't, she still can manage a surgery. So it's a very challenging anatomy.
Yeah, I agree. I think this anatomy is challenging, and I think it would need potentially more than one device since it's kind of across the valve in a couple of different segments and you have a small valve to begin with. And I think to me, it'd be somebody that I'd have to really be convinced is prohibitive risk. And I think the point that I think Rob made or someone made about, can you diurese him and get him to a point that they could undergo surgery? So Gilbert, any other thoughts? Anything else that hasn't been mentioned?
Yeah, no, I echo everyone's comment. I think really the decision tree is, can this patient be optimized and do whatever procedure in a more elective setting, or basically this is more urgent procedure with a bridge to decision, either surgical or with a good result. One of the attendees actually asked a question to the panelists. How many of you guys have expertise in urgent mitral clip, kind of like a case like this, versus an elective setting?
You want to start by answering that?
Yeah.
Well, me personally, I've done a couple cases. Patient in shock, where patient is really prohibitive surgical risk. We definitely ask our heart failure cardiologist and our anesthesiologist to optimize the patient as much as possible hemodynamically, and typically, I think you can definitely, with favorable anatomy, get a reasonable acute result, and then tie them over to something more definitive if necessary.
Yeah, I've certainly done them on ECMO in some cases. Myra or Paul, anything to comment?
Yeah, so it happens occasionally. I remember one not too long ago on balloon pump, and it just helps, if you get a good reduction of MR, it helps stabilize the patient and then come off balloon pump or any other support therapies. Sometimes it's needed.
And Didi, what's your thought on the gradient that you see? Is this something real or concerning, or is this just there's so much MR?
Well, the gradient is really flow dependent. And when I was looking at the images, the first thing I was looking at was the leaflet thickness and leaflet integrity. The leaflets look like sails. They're flowing. They're actually having a lot of good hemodynamics to them. So they're not thick and rheumatic in appearance. So it should just appear and it should be okay. The thought process behind what I would be thinking regarding this is we've done a case series of cardiogenic shock and flail leaflets, and it's very satisfying. When the ones that are died at LVs, if we don't get a good enough reduction, then what we end up doing is committing the patient to a mitral valve replacement. And then that goes into the thinking of, can they take anticoagulation or not? So it becomes a little bit more complicated in the thought process of, do we do a clip or not, not beyond the gradient.
All right, Gilbert, Yoshi, you want to go tell us what you did?
Yeah, sorry, I thought I'd show the slide so people know what we did. But since we have an expert, Paul's here. So Paul, can you tell us about the G4 system, what's so new? Because, we have all the surgeon audiences and we're not all familiar with the G4 system.
Yeah, so, the main aspects of the G4 that are nice are that it has this ability to...
Oh, I think we're losing you on your connection.
All right. I guess we lost Paul a little bit there. So,
Mara, you want to?
Yeah, sure. Thank you. The two main
which
features.
allows you to. Can you guys hear me? Okay.
Better now. So, do you want Paul to continue? Or you want me to?
Why don't you go ahead, Myra? And when Paul's back, we can.
Yeah, Paul, we heard half of it or less. I'm sorry, but what I was trying to say, the two main features is, we do have now 4 sizes, so it's still the same small and large size of device that you have it right there at the center of the picture. I don't have control of showing with a mouse or a pointer, but you have the small and the large, and within the small and the large, you have a narrow version and a wide version of each of those. So that allows you to kind of customize the type of device that you need according to the anatomy. So if we have a large valve area and we know that we're going to need more than one device, then maybe for those type of patients, you may want to start with a larger one and a wide one to try to grab more tissue. When you get to the smaller anatomies, like this lady, I would vote that we stay on the smaller side. So I think I would pick the NT, just a regular one to begin with. The other important feature is the independent grasping. So the grippers on the prior versions used to act simultaneously on both sides. So here we have the option, if we, for some reason, cannot capture both anterior and posterior leaflets, you could grab one and then, independently grasp one and then go to the other one. So that's another important feature. The other thing I like is measurement of the left atrial pressure. We used to do that regardless, even with the prior generations, but we had to place a fourth French, either multi-purpose or pictal in the left atrium to monitor the V wave. So one of you already mentioned, I think it was Didi, if we lower the V wave and the mean left atrial pressure enough, this patient may feel better. So we like to monitor that during the procedure. So with this generation of the device, we have that capability without having to add another catheter, which makes it simpler. And now every single procedure will have the option of giving you the left atrial pressure if you want to follow that.
Okay. All right. Thank you so much. So for the sake of time, we picked NTW because we thought that the regurgitation was mainly from the gradient was mainly from the regurgitation. So we did transeptal puncture here, and then we went on to place the clip. Somehow the video is not playing really smoothly. So we really aimed for that prolapsing segment. The prolapsing segment was relatively wide. So initially we aimed for the medial aspect right in the middle of A2P2 so that we can keep the orifice area and potentially get the maximal benefit. This is after the first position that we placed. And there was still a residual gradient that we saw after the first one. In hindsight, this was probably okay. But at this point, the mean gradient was 6. So we thought that potentially we can move it slightly lateral and create more orifice on the medial side and see if that improves both the gradient as well as the flow. So the second attempt was placed slightly more medial. And after this placement, we saw larger jet on both sides. It was quite large, and you can see the quanta effect here. And the mean gradient went up to 8. So we thought this was not good. So the third attempt, we tried to put it in between where we placed. So not right in the middle, but slightly towards the A3P3 side. And still we had some gradients, but we had some regurgitation jet that we saw, but it looked a lot better than the second attempt. And the mean gradient dropped down to 5. What was really striking was the V wave. As Myra said, we were monitoring V wave during the procedure, and it went down from 62 down to 21. And the flow reversal in the pulmonic vein disappeared. So we thought, despite the mean gradient 5 and some residual MR, we thought this was a victory, and we sort of came out. This is the post. This is the following day where we got the transthoracic echo. They read it as moderate MR, and the patient did really well. So she completely weaned off on post-op day number 2. She was out of the CCU on post-op day 1, or post-procedural day 1. She started ambulating immediately, and she was discharged on day 7 to rehab. So, it was not a perfect result, and we had to do a couple attempts to get the optimal result. But at the end of the day, I think she was a pretty...
Tsuyoshi, would there have been any scenario that you would not have deployed the clip? I mean, the first 2, were suboptimal. Let's say you never got to that third one, that you still had either too high gradient or too much residual MR. Would you ever get to a case where you said, I'm just going to pull out and we're got to think of option B, which is surgery? Or
Yeah.
Would you deploy it and then see what happens and know that you're going to replace the valve? I'm curious.
I mean, that's a really good question. And one of the things that we really relied on was the hemodynamics. So the LA pressure really came down dramatically after the first clip. So the first clip that we tried to place decreased the LA pressure to about a half, the V wave to about a half. And then the last one decreased it to about a third. So based on that, despite having that gradient, we thought it was going to help her quite significantly.
And I just want to ask any of the surgeons on the panel, since it's come up in the chat, do you think this patient, you can argue, is prohibitive risk, or at least on label for mitral clip? I mean, we already talked about the STS being 5, may not be representative. Vinay or Rob, any thoughts on that? Let's say they had diuresis, they still look the same. They're still on a bunch of oxygen in the CCU.
Yeah, I think that would certainly be one of the characteristics for frailty. And remember that the vast majority of the patients who are in the STS database are chronic symptomatic mitral regurgitation, not acute mitral regurgitation. So I think the STS really underappreciates the severity of illness in this case. So I think that's what the heart team approach is for. And as a surgeon in this case, if we all said, hey, I think this patient's particularly frail, I think she's going to do really poorly at 82 with a long-term recovery after surgery, even if it's minimally invasive, then I think that's certainly a candidate for, for a candidate for an edge-to-edge therapy. I think that's the right thing. And so that'd be prohibitive risk.
It's an insightful comment. Hey, Yoshi, why don't we continue on with the next case, which is also a degenerative mitral valve. We can go ahead, and this is an 84-year-old female, so in keeping with the previous theme, recent pacemaker for sick sinus syndrome. It's a patient I treated a few months ago. Worsening shortness of breath for 6 months, was about class 2 to 3. Next slide. Creatinine was 1.3. Her STS was 5.5 for repair. Okay, let's play these. Okay, you could see, what you see is a anterior leaflet prolapse. And I'm hoping that some of the cardiologists can kind of pay attention to this and tell me what their thoughts on the posterior leaflet is. A little short, but I don't think it's restricted. That's probably a good picture there. See, anterior leaflet prolapse. Posterior leaflet is a little verticalized. And I think the options are clip, open surgery, mini surgery, repair or replace. What do we consider for a trial? I'm curious what the panelists would think. Let me start with this time with the cardiologists. So Myra or Paul, and then I want Dee Dee to weigh in on the anatomy.
Yeah, I think the fourth option of TMVR trial should at least be discussed with the patient. We know that with repair, we can reduce the amount of regurgitation, but it's not going to be perfect. So there's always some residual regurgitation. I think that leaflet was short. We'll see what Didi thinks about that, but it's not like a super easy piece of cake, clip case or a big prolapse and all that. So I think a TMVR trial, it's an option.
Didi, what do you think about the echo and the posterior leaflet? And I'm sorry, I don't have more echoes for you.
No worries. So there's a hint of a papillary muscle rupture on the anterior portion, and there's like an A2 overriding segment, and it's a redundant anterior segment. So the question is, what can we do? The LV cavity size looks generous, but it's a very long redundant anterior mitral leaflet. So if for traditional TMVR, if what you can see is during contractility, during systole, we're already having anterior mitral leaflet contact the basal anterior septal wall. It's not so much a concern of outflow obstruction with the TMVR device put in there, either transapically or transeptal. It's more about risk of LVOT obstruction with that anterior mitral leaflet afterwards. But if you have a clinical trial device that can actually do a leaflet capture mechanism for anchoring for that mitral valve, then you could do a transcatheter replacement. So the outflow obstruction is a concern. But looking at the LV, this patient's going to drop their EF after you do an intervention either way. So if you did a repair strategy, you could potentially try that too. Now, the posterior leaflet doesn't look tethered, and you could potentially scoop it up And these ways, if you go medial or lateral to where the actual flail component is at, you can scoop the posterior leaflet up. But it'll be an anatomically challenging case.
Paul, I don't know if you have any other thoughts on the anatomy here. Is this something you think could be clippable?
We have treated, with clip some patients who have small leaflets, but this one I would try to put into the TMVR trials. I think Myra said it very well. These are relatively ideal. I mean, we could certainly put a clip on just anything, but it's not going to get the result we want. And MR elimination is our business, and TMVR would be a really good way to go with this patient. I would support that.
And clippability, and do you agree with potentially a TMVR, big R, the replacement?
Yes, I would.
Okay.
Well, let's ask the surgeons now.
Yeah.
Vinay, what do you think?
So quick question first before answering. So 82 had a pacemaker for 6 sinus syndrome, creatinine 1.3, but really relatively stable symptoms.
Correct. She's an outpatient, and her symptoms have been going on for 6 months, but getting worse over the last month.
Other than age, what would cause the prom to be 5?
I think the fact that she was female and her creatinine, I think if you actually look at her body weight, that creatinine probably correlated with a GFR that was a bit lower than a creatinine of 1.3 in you or me.
And so, we all do these interventions. I think Myra said a very good comment about the potential inclusion criteria or exclusion criteria in this case for TMVR, big R, in terms of the angulation of the outflow tract, or the aortomitral angle, the tall anterior leaflet. She may indeed, because volume shifts, and if she got better or worse, that could potentially be a potential problem with the TMVR. But if we just put the risk calculation aside for a moment, and she's an outpatient, eyeball, class 2 symptoms, honestly, this is a highly repairable valve. If she has, assuming she has no coronary disease, this is a high risk transcatheter mitral valve repair, high risk or complicated, as you've seen from our experienced operators on the panel, with 1 or 2 clips and some complexities. But you've got a beautiful seagull deformity there with a mid-secondary leaflet tethering point, dividing that secondary leaflet or an anterior chordal transfer and a ring. This is a potentially easily repairable valve, and I would have probably done this robotically.
Gilbert,
Yoshi, let's go to the questions, and I'll have Rob give his answer while people are voting.
Oh, yeah.
Do that. So the options are, we showed that, all right?
Sorry.
All right, Rob, tell us your thoughts.
Yeah, I really agree with Vinay, which is this looks to be a very repairable valve. And so then it really gets down to the patient and the risks. In TMVR, at least discussing as far as TMV big R replacement, it's important to discuss with the patients that this also includes chronic anticoagulation with those devices, as opposed to a repair strategy, which the patient wouldn't really need anticoagulation specifically for the valve. And at that age, with increasing needs for coming on and off blood thinners, that becomes a risk. And you could even potentially address an appendage closure at the time of the procedure. So I, like Vinay, would say that my optimal strategy for her would be a robotic surgical approach or minimally invasive approach. And then, but if there was anything else in there that made me concerned about her being prohibitive risk or extreme or high risk, I would certainly have a conversation with her about TMVR, big R for trial inclusion.
Good, those are good thoughts. So, she was referred for MitraClip. We spoke about it, whether our heart team was very concerned that the posterior leaflet was going to be difficult to grab. We have some very experienced MitraClip operators, and thought it would be a suboptimal result. We discussed the TMVR big R trials with her. She was having none of it. She really wanted the least invasive surgical approach possible. So we offered her a minimally invasive surgery. I was not convinced that we were definitely going to be able to repair the valve. If you want to go to the next slide, Yoshi. And on the left side, you could see how foreshortened the posterior leaflet is, but it certainly did look long enough that we could repair it. And based on testing, we put, I think, 3 cords and a 32 ring. If you go to the next slide, I think this is the final echo. Oh. Yep. And you can see there's just a small, maybe mild residual MR. And next slide. And then she did well, was discharged early and had a discharge echo, and she's now about 2 to 3 months post-op. So I think, you know, these 2 cases demonstrate a few different things. First, that's clearly the STS is not the only factor in the decision. I think people brought up the heart team, which I think is really critical at all of your centers to discuss together. And presenting to the patient the pros and cons of all the different options. I think those are also important. And being honest about the pluses and minuses, the recovery for surgery and the potentially suboptimal result. Anybody else have any comments about these 2 cases?
Yeah.
Could I just ask a quick question? So, you know, relative to my comment earlier, you know, here's an 84-year-old, you know, the survival benefit of repair or replacement might be debated in somebody in that age group. You know, this is obviously what we would want. We want a great repair. How can you just educate the non-surgeon on like how quickly you did this compared to how quickly somebody would do a replacement? You know, and those types of different effects on the patient and the outcome.
Yeah, certainly I think it depends on the operator. I wouldn't call myself a fast surgeon, a lightning fast surgeon, but I don't think this repair was substantially longer, let's say more than 10, maybe 15 cross clamp minutes longer than a replacement in my hands. I think the other panels might be even quicker than me. I think in terms of the thought process, I know Didi brought up that the LV was a bit dilated, and I was concerned about that. And I think long-term that probably does, long-term is relative to everybody, but long-term that probably is maybe more important if you say, let's take the MR off the table, whether it's a replacement or a repair. And I think you can make an argument certainly for replacement, but this was actually pretty good quality tissue and a lot of leaflet, which then makes it easier to repair. If we have multiple segments and we have to do resection and cords and something complicated in 84, you know, I've been burned in the past of trying to spend a lot of time repairing it. And you know, in this case, it really wasn't that hard.
And Paul and Didi, I will add that, you know, these are all retrospective data, but there is some evidence suggesting that even in the elderly, even in the octogenarians and nonagenarians, mitral valve repair actually does provide some benefit. And the survival benefit doesn't really have to take 5 to 10 years, you know, avoiding the anticoagulation. I don't know what other components that really goes into that benefit, but there are some evidence that shows, you know, mitral valve repair, even in the elderly, are beneficial. So I think that's why we're really trying to repair these valves as much as possible whenever we can.
Well, I think that's really good to hear because, you know, with the repair MR trial coming about, those are some of the questions we're going to be looking at. You know, when somebody is in that age group, will the surgeon, you know, obviously want to take the time to repair the valve and get that result? I mean, if you get a repair like that, what Gorav just showed, MitraClip is going to have a tall order for competition. So, I mean, that's a great result.
Yeah, so what Paul is talking about, the repair MR trial is an Abbott trial that will look at intermediate risk patients, which will be randomized to surgical mitral valve repair versus the MitraClip procedure. And it's started to enroll, right? I mean, I think it's going to be a highly anticipated study, and Paul's a national PI, so.
Yeah, I will mention that in this particular pathology with very short posterior leaflet, one has to be very mindful how much coaptation you restore at the end of the surgical repair. Because with a dilated LV, if there's adverse remodeling, you might end up having more restriction of the posterior leaflet, and you might actually have recurrent MR after surgical repair, you know, in a few years, whether it's from fibrosis or LV dilatation.
That's a great comment, and that is connected to my question. My question to the surgeons was going to be related to the choice of repair. So are you taking in consideration the choice of ring, taking in consideration the fact that the patient may come back? She's 84 now, but the statistics say, what is a third of the surgical repairs or replacement will come back within 10 years for a repeat intervention. So she's going to be much older. Are you choosing rings that are going to be favorable for a transeptal valving ring in the future?
Do Rob or Vinay, what's your thoughts? I mean, clearly I used a complete ring here, but
I would say in most instances, I don't use a complete ring when we're just talking about standard degenerative valve disease, unless it's been complicated by longstanding atrial fibrillation or or some sort of non-ischemic cardiomyopathy that's affected the ventricular size and geometry. So in this case, where the ventricle is much more dilated, I would consider a ring. In that case, it would be semi-rigid, which would work better for a valve and ring. But this patient still would need a complex valve and ring should it happen, because she had such a very long anterior leaflet. She would not be just a straight up favorable valve and ring candidate, even with a good leaflet separation procedure or leaflet division procedure. She still would be a potential risk for LVOT obstruction. So really, I mean, I think all of us, when we're fixing a valve, we're thinking about doing the best job we can fixing that valve. And if we do a good job with that, actually, for bileaflet prolapse or anterior leaflet prolapse, if you look at 20-year outcomes, obviously these are all very prolific sites with great outcomes, but it's about a 25% chance of reintervention over a 20-year period of time. So that's pretty reasonable. And at 84, trying to get to 90, I think your odds are pretty much in your favor if you get good coaptation at the end of your case.
Vinay?
I would say two important points to Paul's question. There is ample data. In fact, one of the earliest linked STS analyses with CMS data was exactly this question, is looking at the longitudinal outcome over 10 years of patient over the age of 65 linked to CMS. The results are exactly like the Mayo series in younger patients. So there is very clear evidence that repair is superior to replacement in the elderly population. Matched, linked, longitudinally, propensity matched data. So second point is this is a situation I think Gorav mentioned. You have a lot of redundant tissue. Yes, the posterior leaflet may be restricted by echo, but probably the coaptation length of the posterior leaflet was relatively sizable. And basically the repair that Gorav did, I would have done something slightly different, but the general concept is anterior leaflet coaptation restoration. And in this case, whether you add Gore-Tex cords to right size it to the posterior leaflet length, or you divide and do a chordal transfer of that anterior leaflet, this is going to have a good long-term result. This is a pretty highly repairable valve, and I wouldn't be worried about a recurrence in this particular case.
All right, great. Yoshi, what do you think? Should we move on?
I think so. We got two more cases.
Great discussion. Thank you, everybody. Yeah.
All right. Next case is going to be presented by Gilbert. You want to take over, Gilbert? I'll run the slides.
Sure, thank you. Sorry. So this is a case that I presented previously before in another meeting, but I want to highlight some points here. So it's a young lady, 59-year-old, but in class 4 heart failure. She has both prosthetic MS and MR, and the re-op risk is not terribly high, but still, 6.7%. This is interesting. So she actually had a minimally invasive mitral valve replacement in 2005 with a Paramount valve, 27 millimeters, and had a multitude of complications, including right phrenic nerve injury, had the trach and ischemic bowel, and requiring surgery, and really left her quite debilitated, requiring home oxygen with COPD, pulmonary hypertension, AFib, etc. Coronary is normal. Peer pressure was quite high at the time of the right high calf, 90/40. EF is still relatively preserved at 66%. Yoshi, can you try to play the video? I'm not sure why they don't play automatically. And you can see here, the prosthetic valve has really kind of run its course of time. The leaflets are pretty fibrous and calcific, certainly a lot of MR. You can see a high gradient, mean grade of 15. Just of interest of note to our panelists here, the septal wall thickness on 10 in terms of other potential therapy associated with this decision making. Of course, with these kind of patients, we typically do a CT, gated CT to look at some of the anatomy of the mitral prosthesis and LVOT. You can see here, the native LVOT is on 307. The neo LVOT, to put a SAPIEN 3 valve in there, is rather small, 150 millimeters square or so. And the aortomitral angle is on 120. So we discussed the patient whether to do surgery again versus transcatheter mitral valve replacement of a valve in valve. And you can see there are some concerns from a procedural standpoint. When we can talk to the panel about this in terms of LVOT obstruction. Is this small neo LVOT clinically relevant to this particular patient who is not, very mobile and active? And the question is, what size SAPIEN 3 valve would you put in there? So with that, I'll pause and maybe Yoshi, you can moderate.
Yeah. So maybe I'll ask Didi first about this neo LVOT, the concept and what it means and what kind of numbers we're looking at here.
Yeah.
We
So
can look
thanks,
at the next
Yoshi.
slide as well. Sorry. The next slide is
So going back to the original one, so I mean, just looking at the size right here, the area that you got for the valve was 531. Okay, if you go to the slide before this that Gilbert was showing, if you can play those images again, number one, there's two things that catch our eye. So the concept of neo LVOT is really just the new outflow tract, and the outflow tract issue of concern is the most ventricular portion of the surgical valve that potentially could make contact with the basal to mid-anterior septal wall. And we basically induce a permanent anterior motion of the mitral leaflet of the surgical valve, which would then cause outflow obstruction, because the surgical mitral prosthesis will always open systole diastole to allow blood flow to happen. But when we put a transcatheter heart valve within their surgical device, the leaflet is going to be permanently motionless. And that's what the problem is. In this patient, they have severe MR and severe MS with a degenerative bioprosthesis, but on top right-hand corner, they have severe RV dysfunction. So the mechanism for neo LVOT is multifactorial. One, it could be that they have a basal anterior septal hypertrophy or some kind of Holcomb phenomenon. The other is that they have a severely enlarged right ventricle that actually compresses the ventricular septum of the LV, thereby decreasing your distance between the basal strut to the anterior septal wall. And the third mechanism would be like dialysis or fluid volume issues, where the patient actually is just completely hypovolemic and then their LV is hyperdynamic. Those are the main three things. Last one would be like if it was not a surgical, but a valve and ring, any kind of subcortical apparatus. So a neo LVOT, usually less than 190 is where we see an MVARC change in a gradient of peak to peak of over 10 millimeters of mercury. It's been done as low as the 135s, as long as there's going to be an LVOT gradient afterwards. Now, in the Holcomb literature, if we have a peak to peak of 40, we get symptomatic. 10, not so much, but MVARC has established that surgical criteria is 10. But this patient's at high risk for a gradient with a 26 S3.
Thanks,
So
Didi.
Didi, what would you recommend then? You think transcatheter approach is not ideal?
Well, she's 59 years of age. The few things that come into my mind is that if we do a transcatheter mitral valve replacement, she's going to need anticoagulation. And there's anemia in here that we don't know what the deal is with the anemia. She's also got his RV dysfunction. So she's going to be at high risk. And as Myra has really elegantly demonstrated in the mitral trial, that the 1-year mortality with underlying pulmonary hypertension and RV dysfunction is significant, needs to be of concern. Ideally, she would get a tricuspid ring and a complete surgical mitral prosthesis redo and give her time to buy something. But she's going to potentially need some kind of septal ablation or LVOT modification if the valve dives too ventricular during the deployment.
So Gorav, we can do the poll question for this one. So I'm going to have people do the poll and then have the panelists comment on what they
Myra or Paul, do you have anything else to add with your experience?
I'll just be very brief because I think Paul has experience in this type of patient. So this is a very different anatomy like Didi already described. I think there's the RV pushing the septum. So it's a different pathology. This is not septal hypertrophy. And your options of septal reduction therapies are not going to work here. You could do percutaneous laceration of the leaflet, but I think even there, the risk would be significant. So I know Paul has experience. You want to mention the other alternative or?
Well, Myra is versed on this because she was on the panel when Vinay Badhwar and I just did another case of this last week. It was actually a 29 paramount with no neo-LVOT as well.
Or maybe we're not supposed to say that yet, Paul? I
Yeah,
apologize. Maybe
I don't want to disclose. I don't want to disclose too much about that.
Let's go to the survey then.
Yeah, she's aware of the case, but you know, I don't think there's any good option here unless you do.
We lost him.
Okay, Paul, you're breaking up, Paul.
Yeah, sorry, Paul. Maybe they don't have internet in Minnesota. Minneapolis, there's a lot of rides.
Yeah, not a lot of.
No LVOT, and there's no room here.
Okay. Vinay, do you want to comment what you would do?
So obviously it's pretty high risk all around. I guess the question really is you described, Gilbert described the pre-operative risks and the initial operation, but how is she now? And I know that the predicted risk was 6.7. This is going to be a tough case no matter what. You've heard everyone comment. If she's 59, she's not going to have a third time re-op, so she's likely going to need a mechanical valve if a surgical approach was done, transsternal, of course, and then that way you can take care of all of this stuff. And a lower profile valve to free up the left ventricular outflow tract and take the other one out from a surgical standpoint. I think what's not even listed there is actually a surgical re-op.
Full surgery.
And so I think that should be on there, to not just completely discount, because that's the most pure anatomic reconstruction. So obviously it's going to be high risk. That being said, if she is otherwise of prohibitive risk based on what you feel, then I personally would vote for a valve-in-valve and just live with the consequences personally.
Robert,
any other thoughts?
Yeah, honestly, looking at this page, this is someone we'd bring in ahead of time. We'd work on trying to optimize with diuretics and inotropes and see how that RV starts to look before we made a complete determination of surgery versus transcatheter approach. But in this patient, we've done this a couple of times. We know we're going to have a high risk transcatheter case, but what we're really trying to do is get them a year out, maybe, try to reduce the pulmonary pressures. If we have, as Didi was talking about earlier, if we have a neo-LVOT, that's got a gradient of 10, 12, even 15, not ideal, but survivable, doable, and you can get that patient potentially to a much better circumstance where their RV's working better, their PA pressures come down, because that valve's not going to last forever, but it may get them a year or two of getting better so that you can get them to a surgical valve. And that's probably where we would be thinking first line, unless they made, significant improvement in their overall.
So valve-in-valve as a bridge, if they survive, they have. That's
yeah, because she's only 59.
I guess would you also agree with Vinay that the patient would need a mechanical valve if you did an operation? Do you think this patient has a life expectancy to get him through surgery of 10 plus years?
I don't think you have to. I think that's also another discussion, because with all the other stuff she had, she may be a very poor candidate for anticoagulation, which makes transcatheter valves also tricky. That's why I think if you're doing a transcatheter valve-in-valve, you're thinking of this as a bridge to another day, really, more than a long-term therapy for this patient.
Paul, did you have anything else to add since you got cut out?
Let's say something real quick. Is it?
Yeah, can you hear me now?
More on the low profile as opposed to mechanical.
Got it. Yeah, I can hear you, Paul. Go ahead.
Oh yeah. So I'll just tell you what we would do. We would do this with hybrid in the OR, in a hybrid OR. And we've done this before where the surgeon has directly resected the leaflets and done a valve-in-valve. And it's very quick. You can do it in 15 minutes. And we had a case just like this recently where we had concerns about the RV and the PA pressures, and we were in and out very quickly.
So you did it on pump, stop the heart, cut the
Correct.
leaflets out, deploy the sapien valve under direct vision. So kind of like that fourth choice, it looks like.
Yeah, and it worked very well.
I guess
I have a quick
as a
question.
surgeon, I'm sure the other surgeons probably feel the way. If you feel that way, if you're going to go ahead and do that, then why not just take out the valve and probably get a
Yeah.
bigger valve, a bigger EOA.
And it's a good discussion, as long as there's not concerns about PPM, because that is going to be one of the major issues. But it does reduce the amount of time. And my surgical partner, Vinay Badhwar, says it saved him probably 40 minutes or more, which can make a big difference when the RV is not so good. So, that was our approach, and it's worked well.
I have a question for all those surgeons here. So, Yoshi, if you can lead this question, educate us in the cardiology world, the transcatheter world. When you see the bioprosthesis on a redo like this, thickened and calcified, if we were going to use Bovie technology and try to lacerate it or balloon it or anything, what's the risk of that debris flying off? Should we be using cerebral protection in these cases, transcatheter? I mean, can you educate us on what you feel?
Well, I think the calcification that you see in these bioprosthetic valve deterioration is a little different from the native calcification, right? I think the native calcification, when you try to take them out, it comes in pieces. And I think those are the ones that we really get concerned, especially MAC when you're trying to debride them. I think those are the ones that really are nasty. When you see calcification on these bioprosthetic valves, they're completely different. So they're sort of in conjunction with the leaflet itself. And I think the chances of these really coming off, I don't think it's that high. So I don't know if you have to do a cerebral embolic protection device because of the bioprosthetic valve calcification itself. I mean, I don't know if anybody feels differently, but
I think we really have such a novice experience with both the protection device as well as this procedure. It's really hard to know.
Yeah. I mean, my concern about using a SAPIEN 3 valve is that, unless if you really break that ring, the valve is going to have a incomplete expansion. And the pinwheeling and, what's the durability of that in this young patient, I would be a little concerned about it. But for a temporary procedure, it's not a bad choice. If you think that the patient's really sick and you can't really get them out. I've done a couple of them too, so.
Yoshi, I think the challenge here is that with the neo-LVT being so small, a break in the ring and expanding the valve further would really be dangerous. And so I just don't think it's a good option, even though it's technically possible, but it's only a 27 paramount.
All right, Gilbert, you want to tell us what you did?
Sure. So as you can see here, we actually decided to went ahead with a transcatheter approach. The patient was pretty adamant about giving her, pretty bad experience with the last surgery with all these complications, and she pretty much did not want it unless there's absolutely no option. So interestingly, I think at the time of the app, they recommended 29, but afterwards, I think Vinay modified to 26/29. So we went with overexpanded 26. With the understanding that, we might have to bail her out with putting her on pump if we have to, if you crash in the room. So you can see that here, we did that successfully, and we, closed the ASD, and that can be a conversation among the panel as well. But we felt that given the pulmonary hypertension, a bad RV, that we don't want to leave any residual, any kind of intra-atrial shunting. And you can see hemodynamically here, the peer pressure really came down significantly, including the left atrial pressures. She actually went home in 7 days. She's actually 3 years out now. This is obviously just 30-day data, but she really gone off the home oxygen and with a really good outcome. Then you can see the next slide. I think we did a
What did you do for anticoagulation? Can you tell the audience?
Yeah, we put her on Coumadin for 3 months. She had AFib already, so it was not an issue. So we put her on warfarin for 3 months at least, and I think that's what we.
And then after that, she discontinued. She was off anticoagulation after that, or was she on a NOAC after that for AFib?
Yeah, I think if I remember correctly, she stayed on Coumadin because she's been pretty stable on Coumadin. So we did not change her at all. But if you go back to the CT slide, Yoshi. Yeah, so you can see here, maybe Didi and Myra and others can comment. You can see the post-CT. Certainly, there's not much room between the stent frame and the septum. But we felt that because it was a mixed MS-MR etiology, it's not like a native or normal surgical valve. Maybe the surgical leaflets did not go all the way down to the commissural post at the bottom. Maybe they just got lucky and get pushed out sideways and got clearance on her LVOT. The gradient was not really remarkable at all.
Do you have a neo-LVOT area, like a view of the short axis?
I don't think I have it here. Do we have a next slide?
I don't think so. No, I think that,
Yeah.
we do. Yep.
Yeah, do you see it? Yeah, here.
Well, it looks like on the echo that the surgical bioprosthetic leaflets didn't extend to the most ventricular portion of the struts by the transcatheter valve device, because you can see flow through the sapien stents. So it's a really nice result. The difference with the neo-LVOT concept is the neo-LVOT was designed for TMVR and mitral annulus calcification, because those are the most high-risk procedures, and they can be translated for valve and ring. Is now been applied to valve and valve, which is actually kind of a different beast because the native anterior mitral leaflet's actually been resected. So you can potentially go lower in these patients, but the original 190 cutoff is more applicable for TMVR and MAC. And you'll still see a gradient in the valve and valves, but this is a situation where you don't have an anterior mitral leaflet to worry about. You can't predict that.
So we are really tight on time, but I do want to just spend 3 minutes on the last case. This is a
Okay, so I'll go really quickly, Gorav. Yes.
This is a MAC case, and I know a lot of surgeons are dealing with MAC, and I thought it's important to highlight some of the different options for big MAC. Go ahead.
Yeah, so 82 class 2 symptoms, was found to have mitral stenosis, more symptomatic, mitral mean gradient of 12 in mild to moderate MR. LVOT gradient was present with peak gradient of 31 millimeters of mercury. And this was from a thickened septum. We did the preoperative CT scan, the area measured to be about 723-ish. And this is not a perfect LVOT obstruction, neo-LVOT calculation. And, you know, our radiologists use a 20 millimeter sapien valve on a 730 millimeter valve, but still the neo-LVOT came out as 1.2. It looked like it was going to completely obstruct the LVOT. These are some of the other pictures that I got from Rob and Didi, but I'm going to skip for the sake of time. So the options, I'm going to go quickly. Mitral valve replacement with complete annular decalcification and patch reconstruction. Mitral valve replacement with limited decalcification. Transatrial TMVR, or Rob and Gorav, I think you guys performed the Citral procedure plus septal myectomy. Transseptal TMVR with Lampoon. Alcohol septal ablation with transseptal TMVR. Or others. So for the sake of time, I'm just going to continue and tell what I did. So these are the pre-op TEEs. You can skip this, Wesley. We don't have enough time, unfortunately. And this is not playing. You can sort of see the thickened septum, and there was a gradient across this LVOT, so this was quite significant. Sort of stopped. Great. Okay.
Well, Myra, I see Mac. Do you see Mac?
Yes, and I just, before you go to the end, I just wanted to mention one more measurement that I think it would be important would be the skirt neo-LVOT. So when you need to decide between alcohol ablation versus Lampoon, none of those options are completely, you know, are going to give you a result that you want for sure. So sometimes Lampoon, even though you know it may be adequate, may not give you enough reduction of the gradient, or vice versa. So if the neo-LVOT, if the skirt neo-LVOT is low or small, even after Lampoon, you can have obstruction. So I think alcohol ablation would be needed in this case if you were contemplating Lampoon after that. But I see you went open.
Sorry, Myra. I didn't mean to interrupt, but for the sake of time, so start off with septal myectomy, and then resected the anterior leaflet. And I do put the cuff around the leaflet first. I know that Gorav and Rob, I think you guys put it in the annulus. I typically secure it in 4 places.
Mm-hmm.
And then this was the implantation. So, you know, we can go really, really slowly and make sure that all the tissues in all the MAC is captured. And I usually take really long time to make sure that it's in the place that where I want it, and I secure it with the sutures at the end. So I thought this was a really cool view. This is the Neal LVOT when you're actually looking through the aortic valve. I had this view because of the septal myectomy. And you can see that this area literally is the Neal LVOT when the heart starts moving. This is the post-op TEE. There was no more gradient across the LVOT. And this is the view from the picture from Gorav. I think Gorav did a similar procedure through right thoracotomy, did the septal myectomy. I know that Rob does this robotically, and you guys reinforce it with a felt and then place a sapien valve inside of it. I'm going to skip these slides. So one thing that I wanted to touch is that there is a transcatheter mitral valve replacement options for these mitral annular calcification. One is through Apollo and the other one's through Summit. And we have the expert here, Vinay, Gorav, and Paul. So
Paul, do you want to make a comment? You're the national PI of the Summit MAC arm. I know you've had a tremendous amount of experience, and maybe is it, just maybe a word of it overall, and then particularly this case had been a candidate for it.
Well, I think the early feasibility data on Tendyne and MAC has been very, very promising. There have been no operative deaths in that cohort, and so that's why we're studying it in the Summit Pivotal, and it's enrolling really, really well. This case would not have been approved because of the neo-LVOT, so I think you did the right thing. You had to address both the anterior leaflet and the septum, which you did very well. So while I would have liked to have this patient in Tendyne Summit, it would not have been possible.
And what is yours and Myra's?
One more trial, yes. Mitral 2 trial has been approved. So we're working on hoping to start enrollment this year. That will be transeptal only. There's the only option. Alcohol ablation and or lampoon are allowed, depending on anatomy and the expertise of the local center. But so
Myra, I was going to have you present this slide, so sorry about that.
Myra, do you think a septal alcohol ablation would have been sufficient? This is a big septum.
No, but in preparation. So I do see that as adjuvant therapy. So just like you did myectomy during a transatrial valve in MAC, sometimes the septal ablation may be helpful in prepared. If that's enough, great. But if that's not enough, that can prepare.
How much of an interval do you have, Myra, between the septal ablation versus?
3 to 4 weeks. So I think one option, if you have the right anatomy, one option would be alcohol ablation. Repeat the CT scan in 3 to 4 weeks. And if this is favorable anatomy for lampoon, and you still don't have a neo LVOT that is adequate enough, then you can go ahead and do lampoon. But if despite that your SCRV neo LVOT is not good, then there's RF ablation, another option that you could do. There's more septal reduction therapies that you can do to prepare that patient for a transeptal. So unfortunately, many of these patients need that type of work. So it's not, and that's an extra,
there are a couple comments about is there any resources you can direct people to how to learn to measure the neo LVOT? I know you've written about this, so.
And Dee probably would be the best person to talk about that. But
any reference it, and feel free to put it in the chat or something if it's something you can pull up. But I think that'd be helpful for the surgeons, particularly since I know it involves some software that not everybody has.
Yeah, no, it's readily available, commercially available. I would say PubMed, Myra Guerrero's last name, and then you'll find out the neo LVOT on there. She's done tremendous work on this. It's actually from the 1960s from the surgical literature. You guys taught us about the neo LVOT with Sam and Pam, so we're just bringing it back with transcatheter mitral valve. The software is by CT. It's a contrast CT beforehand, and it's commercially available. Any package that does TAVRs.
Great. Rob, any other final comments since you have taught us all Mitral and been championing it?
No, I mean, that was a great result. Gorav and I do it a little bit different, but I think the outcome ends up being about the same there. I think, a lot of times there's a bunch of different ways to skin a cat. I think the really important part of doing a surgical approach is it's really just meant to be complementary to the transcatheter approaches. It's not one way or the other way. It's having all things available to your heart team when you're making these discussions and plans. So I think the transcatheter approach is a great way to do it. We look at that first always, and then we look to the surgical approach.
Vinay, is there any more role in doing a big Mac resection and patching? Do you still do that?
I still do that, and but of course, it's all about judgment and experience and comfort and safety. So this is just highlighting the entire excellent webinar you've put on. So I want to thank you for that. It's really about the heart team, as all of these types of discussions. All of us have collaborated on them, every single panelist, and all of us have been talking about this for years, and we learn something new every time. But this is all about heart team, as has been said multiple times.
Great way to wrap it up. Yoshi, any other final comments about this?
No, I really want to thank the panelists and the audience for participating and giving great comments, excellent comments, real expertise. A word of wisdoms we were all over. And I think we had excellent questions. So thank you for giving us the opportunity to do this again.
Yeah, thank you. And I want to thank these panelists are outstanding. I mean, truly experts, and showing us how the heart team between cardiologists and surgeons and imagers can really work well together. So thank you all. Thank you, the audience, for your time, and please stay well and be safe. Have a good night.
Thank you.
Thank you.
Thank you, Dr. Ailawadi and Dr. Kaneko, and thank you to all of our panelists today for your participation and insight. A reminder that the archived version of this webinar will be available tomorrow at sts.org, as well as on the STS YouTube channel and the STS Surgical Hot Topics podcast. We would like to thank Medtronic for supporting the STS Summer Webinar Series. Thank you all again, and we hope to see you back here next time.